All right, so today we're going to talk about back pain evaluation and management. And so just an overview, we'll start talking about some definitions and terminology when referring to the spine. We'll go over the anatomy, the natural history of most back injuries, how we evaluate and treat back pain, prevention strategies for back pain, and just an overall summary. Now, in terms of definitions, one thing I'll define is just the acute, subacute, and chronic pain. And so the significance of this is that we approach and treat acute pain different than we do subacute or chronic pain. And acute pain is defined as pain from 0 to 4 weeks, and then subacute to chronic is longer than 4 weeks. The term spondylosis is just referring to our arthritis in the spine, whether it's the disc or the joints. Spinal stenosis means narrowing in your canal, so it's a very non-specific term. That there's a lot of factors that can narrow the canal and put pressure on nerves. And then the term radiculopathy refers to if there's a nerve that's pinched in your spine, and that can cause radiating pain down an arm or a leg, numbness, tingling, weakness. And then the most concerning symptom of neurological impingement would be cauda equina syndrome. And that's where you have severe narrowing in the central spinal canal that can cause bowel bladder dysfunction, numbness in the saddle area, and lower extremity weakness. And that's kind of one of the few neurological emergencies with back pain. Now, in terms of the anatomy of the lumbar spine, so on the left right here, you have a picture of the entire spine. You can see it's divided into different sections. You have the cervical, thoracic, and lumbar spine. And then with the low back pain, you're kind of really focusing on the lumbar spine and the sacral region. And then kind of zooming in a little further here on the right side, you have the bottom of your lower lumbar spine as it goes into the sacrum, and the sacrum is triangular shaped bone at the bottom. And then where the sacrum connects to the pelvis, it's called the sacroiliac joint. And we'll talk more about this later, but the sacroiliac joint is a very common source of spine pain. Now, looking at the spine in even more detail, so here on the left, you have the individual vertebrae. And between the vertebrae of the spine bones, you have the intervertebral discs. Now, these discs serve to cushion between the bones, and they also allow for motion of the spine. Now, in the back of the spine, you have these little joints where the bones come together here on the left, and those are called the facet joints. Those facet joints are another common source of back pain. And then over here on the right side, you have another model of the lumbar spine. You can see how these nerve roots come out these little holes on the side called the foramen. And these nerve roots go down your leg and to different parts of your leg. So they can cause pain and numbness in different distributions. And they also go to the muscles in your leg. And so they cause your muscles to move. And then up here, I also want to draw your attention to just an overhead view of the intervertebral disc. And you could just look more at the morphology of the disc, and you can see how the disc is really kind of like a tire. And the tire portion of the disc is called this annulus. And then within the tire, you have this jelly-like center called the nucleus pulposus. And then we'll talk more about the significance of all those features later on. Now, in terms of the natural history and the epidemiology of back pain, so back pain is incredibly common in humans. So at some point in your life, about 84% of adults will have back pain. Majority of episodes of back pain are what we call nonspecific, meaning we can't identify a cause. However, majority of these episodes do resolve on their own, and 70 to 90% of these episodes of back pain actually resolve within 7 weeks. So on a small percentage of people, the back pain will last longer, and it could go into subacute or chronic pain. Now, because acute back pain, so pain of 0 to 4 weeks in duration, does self-resolve on its own in a majority of people, oftentimes treatment is just symptomatic, so allowing your body to heal over time and really trying to give you some pain relief while your body's healing on its own. Now, we start to treat kind of acute back pain with safe interventions first, and then we kind of usually start with heat, ice, rest, massage, acupuncture, spinal manipulation are all very safe interventions. If that's not providing satisfactory relief, sometimes we'll add medications. NSAIDs, so non-steroidal anti-inflammatory drugs, or muscle relaxants can also be helpful to give some symptomatic relief. And then also activity modification, so avoiding activities that are painful while your body's healing from your injury. Now, in the past, they used to put people on bed rest a long time ago, and they actually found that's not a good thing to do for acute back pain, and that individuals who are on complete bed rest actually have more pain and a longer recovery period. So we try to avoid that now. Now, occasionally with acute back pain, if it doesn't get better, then we start talking about imaging. And the reason for imaging is really to make sure there's nothing dangerous causing your pain. And dangerous causes of back pain are incredibly rare, but dangerous causes would be trauma. So if you have trauma to your back, you'd be worried about some type of fracture, infection, cancer, and then also if you have significant neurological compromise from a nerve being pinched in your back. So the current recommendations from the American College of Radiology are to obtain imaging if your back pain persists for over 6 weeks and it's not responding to conservative treatment with medications or physical therapy, or if you have any red flag symptoms to suggest that maybe there's something dangerous causing your pain, such as cancer, infection, neurological compromise, or even a fracture. Now, when we get imaging, again, the purpose is to make sure there's nothing dangerous causing your pain, but it's actually incredibly rare that there is something dangerous causing your pain. And below here, you can see the percentages of the incidence of concerning causes of back pain. And really the two that are the most concerning are metastatic cancer and spine infection. And you can see the incidence of those are incredibly low. And then other kind of disease processes that contribute to back pain would be a compression fracture from osteoporosis, which is really just thin bones, and that's not anything that's dangerous, it's just really painful. And then ankylosing spondylitis is actually just an inflammatory disease affecting the spine, but not anything that's dangerous. You would just treat that a little different than just pain from run-of-the-mill arthritis or a muscle strain. Now, imaging actually has an incredibly poor correlation with pain. And so again, the main reason when we get imaging when someone has back pain is to make sure there's nothing dangerous causing your pain. And unless there's something really bad causing your back pain, it's actually impossible to look at that MRI or CT or X-ray and say, okay, that's where your pain's coming from. And the reason for that is because degenerative changes in the spine are actually incredibly common. And there's been a lot of research studies looking at people who have back pain, don't have back pain, and actually the incidence of arthritis and disc degeneration and disc bulge is actually identical in both groups. And the only thing that they found that these degenerative changes correlate with is actually age and not necessarily pain. And as you get older, the prevalence of that is likely to increase. On MRI, there are a few findings, though, that do have a higher correlation with pain. Listed below here, the disc extrusion, severe stenosis, motor changes, and posterior high intensity zones, and we'll talk about these in more detail later on. Now, here's just a little chart from this Journal of Radiology, Journal of Neuroradiology from 2015, and this is just a good example of how common degenerative changes are in people who have absolutely no pain. And so you can see, as you get older, in 80-year-olds, 96% of these people have some degree of disc degeneration and disc bulges, and then less or so disc protrusions and annular fissures. And we'll talk more detail also what these findings are. And then you can see even in 20-year-olds, you can see these abnormalities in the discs. And so just because there's a disc bulge or a disc protrusion on your MRI doesn't necessarily mean it's painful or dangerous, just because they're very common and people have absolutely no pain. So now kind of talking about treatment for when your pain progresses from the acute phase, when really not much is needed other than time and kind of giving you pain relief, to when pain progresses to the subacute to chronic pain, so pain of longer duration. And typically when you first see us for chronic or subacute pain that's been around for a while, we still go through that similar stepwise progression where you tend to start with the safer interventions first. So rest, activity modifications, ice heat, medications, and then kind of manual therapy. And then if that's not working, physical therapy is crucial. And the goal of physical therapy is kind of twofold. So one is optimizing your spine mechanics. So I always tell patients, with chronic back pain, we can't give you a new spine, but you can make the most of what you have. And really the goal of physical therapy is to improve the way your spine functions, improve your range of motion. And that's crucial for long-term spine health, and also probably the closest thing to a curative intervention for spine pain, or as best we have, to really, again, optimizing your own spinal mechanics. And then you have injections that we can do for spine pain. The injections are purely for symptomatic relief. None of these injections actually heal anything. And it really just to give you some pain relief while your body's kind of getting better on its own or managing the pain. And we'll talk more in detail about those injections. Now, in terms of talking about the specific structures in your spine that are causing your pain, that really gets more important when you start talking about injections, because prior to when you get into injections, with all the other conservative treatment options, medications, activity modifications, physical therapy, a lot of it's optimization of your spine mechanics. But then when you start talking about injections or procedures, that's when it gets more important in terms of talking about what specific structure in your spine is causing your pain. And so the most common causes of chronic or subacute to chronic spine pain are pain from the discs, pain from the facet joints, pain from the sacroiliac joint, and then the spinal stenosis is another common cause of pain. And then over here, you see these graphs on the right. The incidence and prevalence of pain from these structures actually is very much dependent on your age. And so in this graph right here, this is looking at disc pain. And you can see disc pain is much more prevalent in younger individuals, and as you get older, the likelihood of having chronic discogenic pain decreases, whereas facet joint arthritis pain actually increases as you get older and is very rare in young individuals. Same thing with sacroiliac joint pain. And then over here, these are the other sources of pain that do increase as you get older, and those other sources could be the spinal stenosis or pain from cancer or fractures, or osteoporotic fractures from osteoporosis. Now, two of those structures, the disc and the facet joints, are where the motion occurs in your spine. And so to your right here is a picture kind of zoomed in of your disc. And again, you can think of your disc as a tire with a jelly-like center. And the purpose of that disc is to absorb loading of your spine and to allow for motion. Now, when you do load your spine, that jelly-like ball compresses, and then it puts pressure on the annulus to contain it. So it kind of transfers that compressive force to more of a tensile force within the annulus. And typically, that annulus is very strong, and the weak point in this disc is actually at this cartilaginous end plate here on the top of the disc. And so usually the first insult to the disc is through this end plate, which is actually a crucial structure because the nucleus has a very high water content. There's a lot of connective tissue in there that helps kind of maintain the ability of the disc to bear load. And a lot of the maintain the integrity of that nucleus is through this cartilaginous end plate. And so you get diffusion of nutrients and water through the end plate. And when you get a disruption in that end plate, that weakest part of the disc, you start losing your body's ability to maintain the integrity of that nucleus. And then this next slide will kind of show you what happens with that. And so there's this concept of internal disruption, which is what we refer to as the discogenic pain or pain from a disc. And the thought process of how this all occurs is initially you get an injury to that vertebral end plate. And then when that happens, you get loss of that nuclear matrix, so that nucleus starts to degrade. And if that can't bear the load of your spine, you get more weight across the annulus. And then as you load the annulus or that tire portion of the disc, then it starts to break down. And below here, you have these two pressure gauges of the disc. And you can see a normal healthy disc, the pressure is going to be evenly distributed throughout the annulus and the nucleus. However, when you get a degradation of that nucleus, you start to abnormally load that posterior part of the disc, and that causes breakdown of that annulus in the posterior part of the disc. And so this next slide, you get another schematic of what happens as you start loading the annulus and you start getting these radial fissures in it. And then the radial fissures can expand over time. Now there's different grades of these annular fissures, and these grade 3 and grade 4 are the ones that are typically associated with pain. And the thought process behind that is that a lot of your nerve fibers are kind of out here on the periphery of the annulus. And once you approach the painful part of the disc, is when you start getting pain. Now, the only way to diagnose this internal disc disruption is actually with two tests that aren't often done anymore. And the reason for that is because they are kind of risky. And unfortunately, we also don't have a great intervention to cure discogenic spine pain. But this next slide will give you an example of what that is. So this provocation discography and CT discography was much more commonly done probably in the 90s and early 2000s. And essentially what you do is you put needles into different discs in your spine and you inject contrast dye at different pressures. And if your pain is reproduced with injection of contrast at a lower pressure threshold than the other discs, then that would suggest that that disc is painful. And then you would put individuals in a CT scanner afterwards and you'd see if that contrast dye leaked out, and you could see it leak out through the annular fissure. And this is just a great example of how MRI can't always diagnose this internal disc disruption and discogenic pain. And you have an example of an individual with back pain, you get an MRI. MRI is very unremarkable. And then the same individual had the CT discography, and you could see the grade 4 annular tears at multiple levels, which is just, again, a great example of when you see us and we get the MRIs, they're really good at ruling out things that are dangerous, but they do miss the common causes of pain often. Now, there are a few MRI correlates that do have they kind of correlate with positive discography. And so these correlates are these modic changes. So sometimes if we get an MRI and we see these bright signals in the end plates just adjacent to the disc, that does have a higher correlation with discogenic pain. And then also the posterior high intensity zone I mentioned earlier. So you see these bright signals in the back of the disc, that also has a higher correlation with discogenic pain. Now, what I was talking about before with that internal disc disruption is just when you have an annular tear, and that doesn't change the morphology of the actual disc. However, if that annular tear weakens the wall of the disc, you can start getting bulging of the disc outwards. And there's really a spectrum of when these discs change size, of disc bulges to disc protrusions to herniations, and occasionally that hernia material can come out of the disc. And the significance of this is that as you get these bulges or disc protrusions and it takes up space in the spinal canal, these discs can push on nerves. And so this next slide will kind of show you the disc kind of bulging out and pushing on nerves. And when this occurs, if it pushes on a nerve, it can cause pain down in your leg, it causes weakness and numbness where the nerve goes to. And so here's just a few pictures of, depending on where that disc herniation is, it could affect different nerves, and then that would manifest in different symptoms down the leg. And so here's just a dermatomal map, and you have different lumbar nerves that go to different parts of your leg, and here's a schematic of where these nerves go to, L1 through L5, and you can see they all would cause pain and numbness in a different distribution in your leg. And these nerves also go to different muscles in your leg, and they're also involved with reflexes. So when we see you and do a physical examination, based on what nerve is pinched, you're going to have a different distribution of pain, different muscles will be weak, and you may have absent reflexes. Now, if you do have a lumbar disc herniation that's pushing on a nerve, and that's called a radiculopathy, the natural history of this is favorable, and surprisingly, your body can heal itself over time. And so from a radiographic history, there's this one study done in 1990 where they were looking at disc herniations and following these disc herniations over time on imaging. And about 50 to 60% of large disc herniations will actually disappear over time on imaging, because your body can heal the disc. Your immune system goes in there and chews it up and heals it. In the clinical history, so the symptoms of back pain and leg pain from a disc herniation and nerve pain actually get better over time as well. there's been a large number of research studies over the years looking at long-term outcomes between conservative and surgical treatment for disc herniations resulting in radiculopathies. And the overall consensus is that long-term, both groups do identical in terms of decreased pain, recovery of strength, sensation. However, that there is a trend that individuals that do get surgery do tend to get better quicker. So because the natural history is that your body can heal itself, we often treat this condition conservatively with that same kind of stepwise progression that I mentioned earlier, with the back pain starting with the safest interventions and then kind of going to the injections. And then surgery would be reserved for those individuals that are having severe pain that aren't getting better with non-surgical treatment, or if you're having signs of progressive neurological deficits. So a nerve is getting pinched and that you're getting rapidly weaker, you're losing bowel bladder dysfunction, and that would be when we get you in to see Dr. Tien to talk about surgical intervention. Now, in terms of conservative treatment, one of the interventions that I perform would be lumbar epidural steroid injections. And in terms of getting people pain relief the quickest outside of surgery, the epidural steroid injections are one of the best things we have to offer. Now, the goal of the injections is really to decrease inflammation associated with your disc injury. So a lot of your pain associated with a disc injury and the radiculopathy is that you get an injury to the disc, chemicals of the disc leak out, and those chemicals in the disc are what we call immunogenic, meaning your immune system isn't used to seeing it. So your immune system kind of goes haywire, it creates this huge inflammatory response, and that's where a lot of your pain is coming from. So the goal of the injection is to get some steroid by the nerve and by the disc to decrease all those inflammatory chemicals to hopefully give you some pain relief. And the goal of the injection is really just to make it so you're not quite as miserable while your body is healing this disc on its own. And the hope would be that by the time the steroid wore off, the disc would heal up and it wouldn't be painful anymore. So these epidural steroid injections don't necessarily heal tissue, but it kind of makes it so you're not quite as uncomfortable while your body's healing on its own. And this picture is just an example of what we do in epidural steroid injection, just an x-ray with a needle kind of going down to this intervertebral foramen. And then we just inject a little contrast dye to verify the outflow is tracked along the nerve. And that's how we know we get the medicine over the nerve in the right spot. Now, beyond these disc injuries, we talked earlier about other common sources of subacute and chronic back pain are the facet joints. And again, imaging correlates very poorly with facet-mediated pain, and the gold standard of diagnosing facet-mediated pain are these diagnostic medial branch blocks. And so the medial branch nerves are these little nerves that carry pain signals from the facet joints. And the way we determine if a facet joint is causing your pain is we can guide a needle down and numb up that little nerve and see if your pain goes away. Now, unlike discogenic pain, where we don't have a great procedural intervention to get rid of discogenic pain, we do have a good intervention to stop pain from facet joints, and that's radiofrequency ablation. So if we do establish your pain is coming from a facet joint by these diagnostic blocks, you can do this other procedure here on the right, where you could put a special type of needle down that heats up and it can actually burn those nerves to stop it from transmitting pain from the joints. Now, the radiofrequency ablation is just what we call a palliative treatment. So you're essentially just blocking pain signals from the joint. It's not necessarily curative, but if an individual has really severe functional limiting pain that isn't getting better with safer interventions like physical therapy and activity modifications and spine manipulation, this is something that exists that can give you some pain relief. Then the other common cause of axial spine pain is SI joint pain or sacroiliac joint pain. And really, again, imaging doesn't correlate well with pain from these structures just because you can get radiographic evidence of arthritis as you get older. So really the gold standard is doing an injection in the joint and seeing if the pain goes away. And this is just an example of an injection with a needle going into the joint. And then one of the last causes of spine pain that I'll talk about is the spinal stenosis, which is kind of a unique cause of pain. And here's just an MRI over here on the right. And if you remember at the beginning, I talked about spinal stenosis just means narrowing in your spinal canal. And so on this MRI, you can see, this is looking at your spine from the side. You have your spine bones, which are the vertebrae. Between you have your discs. Here you have your central spinal canal with your nerves coming through, and you can see it gets really tight in there. And that's that spinal stenosis, and that could be pinched the nerves there. And so the hallmark of symptomatic spinal stenosis is that it tends to be positional pain. So it's pain when you're standing and walking, and it oftentimes gets better when you're sitting or bending forward. And the reason for that is because when you're standing upright, walking, your spinal canal gets more narrow. And when you bend forward or sit down, your spinal canal opens up a little bit and takes some pressure off the nerves there. Now, with spinal stenosis, again, we treat this conservatively at first through the same stepwise treatment of everything else we talked about. Epidural steroid injections can sometimes be helpful with that nerve pain. And then if all that fails, similar to the disc herniation, then you could talk the disc herniation with the radiculopathy. If this is pinching the nerve and you're having progressive neurological deficits, weakness, numbness, bowel bladder incontinence, that's when we talk about surgical intervention. Now, in terms of preventing back pain, so there's nothing we can do to 100% prevent any episodes of back pain, but there are some modifiable factors that we can possibly make a difference. And so one is just leading a healthy lifestyle, so regular exercise, not smoking. And by leading a healthy lifestyle, you could really set your body up to heal from injury. So if you have a disc injury, you can give your body the highest likelihood of healing. As in general, it doesn't really, actually, there's been a lot of studies looking at different exercises for back pain, Pilates, yoga, and they've actually found that although yoga and Pilates are great for back pain, really just any exercise in general decreases the likelihood of you developing chronic pain or persistent back pain. So whether it's walking, running, swimming, it's all going to be good for minimizing the risk of developing pain. In terms of ergonomic interventions, so you could think of your spine as mechanical tissue, and the more stress you apply to the spine or incorrect stress, the more likely that tissue is to fail. So whether it's the disc or abnormally loading a joint and getting joint pain. So just making sure you have a good workplace setup if you work in the office, that you have good posture during the day. If you're slouching during the day working on your computer, you could be abnormally loading your disc or your joints, and that could lead to persistent pain. If you have a job that involves a lot of manual labor, making sure you have good lifting techniques so you're not abnormally loading the disc and increasing your risk for injury. In terms of psychological well-being, depression, anxiety are major risk factors for developing chronic pain, so making sure that's treated appropriately. And then just even having education regarding back pain and knowing that majority of episodes of back pain are not dangerous, that can really play a huge factor in not having chronic functional limiting pain. So in summary, again, back pain is incredibly common in humans. It's rarely dangerous. And then in terms of seeking medical attention, if you have pain associated with trauma to your back, or you're worried about maybe you broke something, if you have fevers, chills with your back pain, that would suggest that maybe it's related to an infection. If the pain's severe, if it's not getting better after 6 weeks of treatment, or if you're having pain raining down the arm or leg, weakness, numbness, definitely you want to seek medical attention. And then when you come to see us, our role is really just to make sure there's nothing dangerous causing your pain. A lot of times that's done through a physical examination, seeing if you have any neurological deficits, and then possibly getting some imaging. And again, the role of imaging is to make sure you don't have anything dangerous. So cancer, infection, fracture, severe nerve root impingement. And then once we establish nothing dangerous causing your pain, we try to get you feeling better in the safest means possible, starting with that stepwise treatment of relative rest, activity modifications, going on to physical therapy, and then possible injections or surgical procedures that Dr. Tien will talk to you about. So that's all I have, and I'll hand this over to Dr. Tien now.
Thanks, Dr. Paluck. That was a really good overview of back pain and lower spinal disorders. My piece of this talk, actually, my name is Raymond Tien, sorry. I've been a neurosurgeon here in Bend since 2004. Appropriately, the surgical piece of this talk is relatively short because the indications for operating in the lumbar spine are actually quite limited. As Dr. Paluck mentioned, the vast majority of people with acute low back pain, they get better on their own. Where surgeons become involved are in the two conditions that he mentioned, and that being herniated lumbar discs and spinal stenosis. And I'll talk very quickly about both of those. As he mentioned, most herniated lumbar discs patients, they get better on their own. And the long-term outcomes of surgery versus non-surgical treatment of lumbar discs, as he mentioned, is that patients do about the same to about 2 years out, irrespective of whether you have surgery or you treat it conservatively. Most people end up about the same. The time that I'll recommend patients to undergo surgery, it's really very limited. The number one, the hardest indicator for recommending that you have surgery for a herniated lumbar disc is if you have a progressive neurologic deficit. So if you're becoming progressively weaker in the leg, that's indicative of progressive nerve injury, which potentially could become irreversible. And so if you're becoming progressively weaker and you have an MRI showing a significant disc herniation impinging on a nerve, that's a pretty reasonable indicator for considering to proceed with surgery. And the surgery is outpatient surgery. It takes 45 minutes to do. It's what's called a lumbar microdiscectomy, and it's performed through about a 1-inch incision in the midline of your lumbar spine. And we gain access to the herniated disc by using a tool similar to like a very precise Dremel tool to make a small opening in the bone that gives us direct exposure to the nerve that's impinged. And then we can gently manipulate the nerve off to the side, and then this disc herniation is usually present and we remove the disc. The recovery from that surgery is relatively quick in terms of the postoperative pain. That's usually present for a week or so. But it's really critical that you recuperate from the surgery appropriately, because there is about a 5 to 10% risk of a recurrent disc herniation if you do too much too soon. So we usually ask people to limit lifting, twisting, and bending for the first few weeks. And then after about 3 to 4 weeks, we'll put people into physical therapy to rehab them, primarily to regain range of motion and core strengthening. And patients can do quite well. In general, I tell people that to recover fully from even these small lumbar disc surgeries, you need about 8 to 12 weeks before you return to full activity. So to summarize, surgery for a progressive neurologic deficit, that's the clearest indicator. The second indicator for operating on a herniated lumbar disc is just intractable pain. And so you failed all conservative therapy, you've had lumbar epidural steroid injections, and this is just really altering your daily activities. And so, and I tell patients this, that you'll usually know when the time to have surgery for a lumbar herniated disc. You'll be there won't be any question in your mind in that you've been so impacted by it, the symptoms aren't improving. And again, it's important that the MRI correlates with the distribution of your pain, and then surgery is indicated. So that's a relative indicator, is intractable back pain, or intractable pain, not back pain, but usually hip, buttock, and leg pain. The second disease condition that Dr. Paluck mentioned is spinal stenosis. And this is also a very common condition that we'll see in the clinic. It usually is in, 60, 70, 80-year-olds. It's a degenerative condition that progresses over time. And the surgery involves, that's also a very straightforward procedure. It's an outpatient procedure, typically 45 minutes, where you're simply removing a little bit of bone and ligament to increase the diameter of the canal where it has been narrowed. Spinal stenosis, usually by the time I see it, is usually severe enough that patients classically are only able to walk a block, maybe 2 blocks at most, before the discomfort becomes severe enough that they have to sit down and sort of lean forward. Under those conditions, like Dr. Paluck mentioned, epidural steroid injections can be tried. They're usually temporary, and they can be useful diagnostically. But under those conditions, surgery can be quite helpful. Again, the symptoms for spinal stenosis that are best treated for surgery is not back pain. It's going to be hip, buttock, and leg pain. Now, you can have some back pain with the hip, buttock, and leg pain, and these things can improve with surgery. But if you're presenting just purely with back pain, midline axial spine pain, in general, surgery is not really a good option. And that's where some of the other treatments that Dr. Paluck mentioned can provide some palliation for your back pain. And so I think what I really would want to emphasize is that in general, your body is an incredible machine. We're living longer, we're living healthier, we're living more active lives, and degeneration occurs under those settings. And so you can expect to develop some level of mild back pain as we age. That's pretty normal. Our goal is to keep you functional, keep you active, not to make you necessarily pain-free. And so for back pain, there's really very limited utility with surgical procedures. Hip, buttock, and leg pain, that in general, that's something that surgery can be helpful with in the appropriate setting. And so here at the center, we try to work as a team looking at these problems together. Dr. Paluck and his group, they'll often be managing a lot of these acute and subacute symptoms, and when it appears that conservative therapy is not being effective, and if you have a condition that appears to be amenable for surgical treatment, they'll often refer those patients to the neurosurgery team for consideration of intervention. And so I guess I'd only briefly mention some of the treatments that have been tried for patients who are presenting with chronic back pain. You'll see lots in online and maybe from people in the community about lumbar fusions. And I think lumbar fusions have their place, particularly in trauma and in spinal instability when the spine is unstable. But for the treatment of axial spine pain, the long-term ramifications of fusing your spine strongly outweigh the short-term gains that occur with spinal fusion. Another technology that has been becoming more prevalent are lumbar disc and cervical disc replacement. And this talk is mostly centered around lumbar disc. Lumbar disc replacement has been around for maybe in the 20-year range. And if you look critically at the data, it's really sporadic. There are some indications in younger patients with focal degenerative disc changes where lumbar disc replacement appears to have some utility, but as a widespread treatment for low back pain, it's really very marginal data, and I'm very hard pressed to recommend it to patients, and it's done very rarely in this community. I think where we're heading really, like lumbar disc replacement, lumbar fusions, those are hammers for the treatment of problems that require, jeweler screwdrivers. And we don't have those fine instruments yet to treat these problems. I'm optimistic that some of the regenerative treatments that are being developed, for instance, stem cell therapies, regeneration of disc nucleus. These are biological treatments that hold some promise in the future, and that are areas of active research, but are nowhere near being used widespread. So I think there's lots of research being conducted in these areas, and there's obviously enthusiasm in the medical community, but we're not at a point as of yet where we can institute some of those finer treatments. So that's just a brief summary. I think Dr. Paluck and I would like to open it up for questions, and there might be a couple in the chat box right now. And maybe we'll start there.
So I could take both of the questions. One question is, I get headaches on the top of my head. Is that related to my back, neck, or something else? It feels warm when it's hurting. So I would say any type of headaches on the top of the head would be probably highly unlikely related to your lower back. Occasionally, the neck can refer pain to the head and cause headaches. Headaches is also another incredibly complex medical field, and there's so many different causes of headaches as well. So typically we would, as a physiatrist, we kind of focus more on the spine, and I'd work up spinal etiologies of the headaches. But I also often work closely with neurologists when people have headaches, just because they're so complex and different types of headaches that can be treated, and that's kind of more their specialty. Now, the second question I have on here is, Dr. Paluck, how long do you wait? I'm sorry, the questions are kind of jumping around as more people type questions in. It says, Dr. Paluck, how long do you wait to have a repeat steroid injections? Do you wait until it's really bad and you can't manage daily activity without pain medicine, or the pain is low to moderate? So there's a lot of factors involved with this in terms of what you're treating with the pain. Is this an acute injury? Sometimes with a new disc herniation with radicular pain, we'll do an epidural steroid injection, see you back a couple weeks later, because it can take a couple weeks to kick in, and then see how you're doing. And really the degree of pain relief that people can get anywhere from 0 to 100. If you get partial pain relief and you're still limited by your pain, sometimes we'll do a repeat steroid injection in close succession to try to give you a little more pain relief and get you through that painful period. However, if it's more of a chronic condition, so if we're doing like a steroid facet joint injection for pain you've had for many years, those you don't want to repeat more often than once every 3 months at most. And then with all these injections, they're really just elective procedures meant to make you feel better. They are low risk, but there are always risks of doing injections in your spine or exposure to steroids. So it's always best, if you can, to put them off as long as possible. So there's the answer to that one.
Yeah, there's another question on chronic sciatic pain in the buttocks, leg, and foot for 7 months following a total knee replacement. Conservative measures haven't worked. When can I just say uncle and have surgery? Yeah, obviously the person writing the question is uncomfortable, and that's been long enough that after a total knee replacement that probably warrants imaging. So I don't know if imaging has been done. An MRI would be critical in terms of trying to correlate whether that pain is related to a particular anatomic structure in the spine causing the pain. So, I think both Dr. Paluck and I would recommend that an MRI be performed and then some consultation to assess whether there's something that can be remediated.
Now this next question, are steroid injections contraindicated in someone with osteoporosis of the spine? So it's not an absolute contraindication, but definitely something to take into consideration. And every time we make the decision to do the procedure, it's weighing the risks and benefits. And so if you do have osteoporosis, it's always good to minimize your steroid exposure because it could potentially make it worse. But if you have an acute radiculopathy with horrible pain and you can't move, then maybe the risks of doing a steroid injection would be justified. In terms of steroid injections for just back pain, you can do steroid injections in the facet joints, but maybe in your case in particular, I'd kind of probably steer you more towards that radiofrequency ablation procedure that doesn't involve any type of steroids. And then kind of going with this next question, how is a facet problem actually diagnosed? So with facet pain and really back pain in general, in my lecture, I talked about the most common pain generators, the disc, the facet joint, SI joint. A lot of it's based on clinical history. And so we kind of talked about how the prevalence of facet issues that increases as you get older. So if you're 20, that probably wouldn't be the first thing that came to mind, but at 50s, 60s, 70s, facet joint pain is going to be really common. Again, we kind of start with the safer interventions first. So medications, physical therapy. If that's not working, then that's when we start trying to figure out is it a facet joint issue. Now, when we select joints, it could be challenging because imaging doesn't correlate necessarily with spine pain. And usually as you get older, you're going to see arthritis in most of your facet joints. So there's been a lot of research studies looking at prevalence of what facet joints are symptomatic. And more often than not in humans, if you have lower lumbar spine pain, it's usually the L4-5 and L5-S1 segments that are most commonly symptomatic. If you have a fusion, it's often the joints that are adjacent to your fusion. And then at that point, if we go on to injections, we're going to do those diagnostic medial branch blocks to numb up the nerves that carry pain signals from the joint. And then if you get pain relief, when we numb it up, then we know the pain's coming from that facet joint. If you don't get any pain relief, then it excludes that joint and we kind of rule it out. So that's the facet joint question. Next question is discuss spinal cord stimulators. So with spinal cord stimulators, you're essentially putting these electrical wires into the spinal canal, and these wires can apply electrical current to the spinal cord to potentially block, or not necessarily block pain, but modulate pain. Now, the classic indication for spinal cord stimulation is typically what they call failed back syndrome. So someone who's had spine surgery before, it didn't get rid of their pain, or they have persistent pain, and they have no kind of current surgical pathology that could be addressed. So it's kind of almost not necessarily like a last ditch effort, but something that can exist to help with pain. Classically, it's designed more to help with nerve pain in the legs and axial back pain. However, with newer spinal cord stimulators coming out, there's been some recent research studies showing that spinal cord stimulation can actually help in some individuals with back pain. A lot of the research, when they show spinal cord stimulation helping with back pain, these are individuals that have both back and leg pain, and also individuals that had prior spine surgery. There's some small research studies looking at spinal cord stimulation for back pain in individuals that have no history of surgery and no leg pain, and some of the results are promising, but there isn't a lot of large randomized controlled trials looking at long-term outcomes. It looks like the next question is also probably for me too, with the plasma injections. And I'm guessing this is probably the platelet-rich plasma. And so with platelet-rich plasma, this is in that category of regenerative medicine Dr. Tien was talking about. And so with platelet-rich plasma, essentially what you're doing is you're drawing your own blood, and there's special machines that can filter out the platelets, which is a blood product. And these platelets have growth factors on it that are thought to help with tissue healing. Now, there are some conditions that PRP or platelet-rich plasma injections have a little more research supporting their effectiveness for. In terms of PRP injections for spine pain, the research, like Dr. Tien mentioned, is incredibly limited. I just attended a spine conference a couple months ago where they went through the current literature in terms of PRP injections for spine pain. And it really is kind of depressing that people have been doing this for many years. There was this one literature review where they went through hundreds and hundreds of papers on PRP. And a lot of the research studies are very poorly designed with small number of patients. And they actually did an aggregate of all these research studies that exist. And they found, despite these injections being done all over the country every day for many years, if you pool all the studies together and you throw out the bad studies, you're only left with a pool of about 40-something patients. And in these 40-something patients, the outcomes were kind of 50-50, in that about 50% of the people may show some benefit and 50% of the people really didn't have much of a benefit. So the overall consensus was At this time, we just don't have enough information. It looks like something that could be promising, and as more research is available, that this could be a possible, more of a mainstream intervention in the future. But at this point in time, we just don't have the data yet. And then let's see the next question. I know I've been talking a lot. I don't know.
You're fine.
If you want to jump in.
Sure. The next question is, can pain and or numbness and tingling in both legs come from disc problems? They can. In general, herniated discs usually cause unilateral pain because the disc usually is protruding to the right or left side. Spinal stenosis tends to cause bilateral leg symptoms. And then there are other causes for pain, numbness, and tingling in the legs, such as peripheral neuropathies. And I think a very common one is sort of a diabetic peripheral neuropathy that can cause numbness and tingling symmetrically, usually beginning in your feet and extending upwards in sort of a stocking distribution. So there are a variety of sources for pain and numbness affecting both legs. And again, typically those things need to be sorted out by somebody like Dr. Paluck or myself, and it usually begins with an imaging study to assess the condition of the lumbar spine and see if there are any of these anatomic abnormalities that could cause it. The next question is, are multi-level disc replacements being done in this country for traumatic disc ruptures? I can only speak most accurately for this community, and that is multi-level disc replacement is not being performed in this community. When we have patients that we think could potentially benefit from them, the people who have the most experience with multi-level disc replacement are the Germans. They've done quite a few of them, and there have been a number of, I'd say in the 15, 17 years I've been in this community, I think I know of maybe a handful of patients that have gone to Germany for multi-level disc replacement. For the question's fairly specific regarding traumatic disc ruptures. And in general, I would say that a traumatic disc rupture is not the indicator for disc replacement. Disc replacement is typically more related to degenerative disc change that can occur in younger people. And there's a chart that Dr. Paluck showed that in 20-year-olds, I think even 30% of people can have degenerative disc changes. And so most people with traumatic disc ruptures, again, fall into that category that Dr. Paluck mentioned, that most of you are going to recover spontaneously on your own. The body has a remarkable way of healing itself. Now, if you have a traumatic disc rupture and you go on to develop chronic low back pain, that's where physicians may recommend undergoing a discogram to see if this is in fact discogenic pain. And if that discogram is positive with appropriate controls that are negative, then in some cases disc replacement could be considered under those specific settings. The next question, I'm fused from L2 to L5, and then there was a maneuver that led to immediate pain. You've had x-rays, a steroid dose pack, an MRI that shows no abnormalities, pain persists. What should the next step be? And the pain is hip, buttock, lower back with sciatica in the leg. This is a tough one, obviously. So, you know, your back has been irreversibly altered with an L2 to L5 fusion. The biomechanics of your spine have been permanently altered, and you've developed some acute inflammation from this maneuver. In the absence of an MRI showing no significant abnormality, there is no surgery to treat what's happening. What what needs to be done is to find some, typically what I recommend is some combination of manual therapies to find a way to break the inflammatory cycle that you may be having. And so it potentially could be an injection, could potentially be, massage therapy, acupuncture, some combination of manual therapies. We see this type of thing with some regularity, and I know it's no consolation, but it usually is a factor of time. And when time doesn't help, that's where I think what Dr. Paluck was mentioning, you start to consider, well, is this somebody that you might do a trial of spinal cord stimulation for failed back? Or is there some injection therapy that can be beneficial? These things tend to help a little bit more for low back pain. When you have radiating leg pain, that can be a little bit trickier, but this is a problem that often has no direct short-term solution to, and typically requires some combination of manual therapies and potentially injection therapies to try to break the cycle. And Dr. Paluck, maybe you can comment on that one as well.
Yeah, the one thing I agree with everything you said. One thing with MRIs showing no abnormalities, a lot of that's kind of how it's interpreted and kind of what doctor was reading it. Sometimes there's subtle abnormalities that there may be something there. Another thing with the discs, especially with you having sciatica or radicular pain on the leg, is sometimes with those annular tears, chemicals of the disc can leak out and cause what we call like chemical radiculitis, where there's this inflammatory response in your spine and that irritates the nerve. And so although there may not be a compressive lesion or a visible disc herniation, sometimes those chemicals leak out, you have the radicular pain in the leg, and we try an epidural steroid injection to decrease the inflammation around the nerves, and people do really well. So that could be another possibility. And then the other thing I'll throw out there too is sometimes joints can refer pain in the leg and mimic a pinched nerve. And so it could be some of the joints adjacent to your fusion. I think I briefly talked about when picking out facet joints, the ones that are commonly symptomatic are those adjacent to fusions. And so maybe that L5S1 joint's a little irritated, or even the sacroiliac joint just below it. Sometimes that could get stressed and refer pain on the leg and mimic a pinched nerve. And so procedures targeting those joints as well would be a possibility.
I think we'll finish up with this question. This is actually directed towards me. It looks like this patient had a lumbar fusion, and then he developed some leg pain, leg cramping with swimming, had to stop, followed by night cramps almost nightly. Are the cramps related to your lower back? Yeah, it's hard to say. I mean, I think I'd have to delve a little bit more deeply into your history and understand where the symptoms are located. I'd be happy to follow up with you, maybe with a telephone call. Actually, I could probably do it tomorrow. I'll check back on the records and see what was done in the past, and maybe a telephone call can help out and point you in the right direction.
Then the last question, I guess from a non-surgical standpoint, I'll read the question. So after 3 back surgeries and hardware from L2 to S5, or wondering L5, more back surgery is out of the question for me. Also, cervical spine is fused with hardware. After 15 years of chronic pain that's been dealt with by steroid injections, massage, mindfulness, meditation, physical therapy, bed rest, other avenues for pain relief without narcotics. And so you've really, it sounds like you've done kind of just about everything out there and all the right things. The one thing that I would suggest that both Dr. Tien and I have talked about would be that spinal cord stimulation could be a possibility. And so it does sound like you're that I would bring this up for. So someone who's had multiple back surgeries, not looking for another surgery, you've tried every other avenue, And sometimes these spinal cord stimulators can give people really good pain relief and definitely does not involve any medications at all.
Great. Well, thanks everybody.
Thank you. Looks like that was the last question.